Thank you for the introduction. Good morning. My name is Yonghoon Shin, and I'm a cardiologist at Korea University Annam Hospital. Today, I will present on what technological advances have improved carotid artery stenting for carotid artery disease. Recently, there have been several updates in guidelines for carotid artery disease. The major ones include the 2022 Society for Vascular Surgery guidelines and the 2023 European Society for Vascular Surgery guidelines. In these recent guidelines, carotid endarterectomy is recommended over carotid artery stenting in many cases. According to the 2022 SVS guidelines, carotid endarterectomy is strongly recommended over transfemoral carotid artery stenting for patients with symptomatic carotid artery stenosis greater than 50% who are not at high surgical risk. Additionally, for patients requiring vascularization within 14 days of symptom onset, carotid endarterectomy is strongly recommended over carotid stenting. The 2023 ESVS guidelines also recommend endarterectomy over carotid stenting as a class 1 recommendation for patients over 70 years of age with recent TIA or ischemic stroke and carotid stenosis greater than 50%. Similar to the SVS guidelines, ESVS also recommends endarterectomy over stenting when revascularization is performed within 14 days after symptom onset. In contrast, carotid stenting often has a lower recommendation class or is considered as an alternative therapy. The ESVS guidelines suggest that carotid artery stenting may be considered as an alternative to endarterectomy for patients under 70 years of age with recent TIA or ischemic stroke associated with carotid stenosis greater than 50%. For patients at high risk for carotid endarterectomy, carotid stenting is recommended as an alternative with a class 2A recommendation. Although not formal guidelines, the 2021 SVS implementation document suggests that carotid stenting may be prepared in specific situations. For example, transfemoral carotid artery stenting may be preferred over endarterectomy in patients with tracheostoma or when ipsilateral tissue integrity cannot be maintained. For high-risk patients with severe uncorrectable coronary artery disease, heart failure, or COPD, carotid stenting may be prepared over endarterectomy in these selected cases. Additionally, unlike the ESVS guidelines, this implementation document suggests that transcarotid artery revascularization, or TCA, may be prepared over both endarterectomy and transfemoral stenting in symptomatic patients with stenosis greater than 50%. TCA is also recommended over endarterectomy and transfemoral stenting for patients at high surgical risk. The SAPPHIRE trial was a randomized controlled trial comparing carotid stenting and endarterectomy in high-risk patients with cardiovascular disease or controlled arterial carotid occlusion, among other conditions. When comparing the two treatments using MACE, which is defined as 3-year death and stroke plus 30-day myocardial infarction, there was no significant difference. This study showed that stenting can be a less invasive option for high-risk patients. However, the small sample size remains a limitation of this study. The ACSM trial was a large-scale randomized controlled trial involving 1,700 symptomatic patients with stenosis greater than 50%, comparing stenting and endarterectomy. There was no significant difference between stenting and endarterectomy in terms of 5-year fatal or disabling stroke. However, the overall stroke rate was higher in the stenting group. The CREST trial was a large-scale RCT involving 2,500 patients with carotid stenosis, comparing stenting and endarterectomy. There was no significant difference between the two groups in terms of peri-procedural stroke, MI, or death, and 4-year stroke rates. Importantly, this study analyzed hazard ratio by age groups. Younger patients had better outcome with stenting, while older patients had better result with endarterectomy. This study showed the possibility that stenting might be preferred in relatively younger patients. Meta-analysis of major 4 RCTs found that stenting showed increased peri-procedural risk with advancing age, while endarterectomy was not significantly affected by age. For patients over 70 years of age, the benefit of endarterectomy became clear due to the increased peri-procedural risk of stenting. Currently, there are limited large-scale RCT studies on TCA. Retrospective analysis of symptomatic carotid stenosis patients who underwent TCA in the United States analyzed 1-year survival rates according to the timing of TCA. Urgent TCA performed within 48 hours showed higher rates of in-hospital stroke and death compared to those performed after 48 hours. Retrospective comparative study between transfemoral stenting and TCA showed that TCA had significantly lower rates of stroke and TIA compared to transfemoral stenting. TCA also showed significantly better outcomes than transfemoral stenting, including mortality rates. A retrospective comparative study between TCA and endarterectomy found no significant difference in composite in-hospital stroke and death between the two groups. The TCA group had more patients with higher medical risk, so this suggests that TCA can be used as an alternative to endarterectomy for carotid revascularization. However, large-scale RCTs comparing TCA with transfemoral stenting or TCA with endarterectomy are still needed. In addition to this, I'd like to introduce further studies on embolic protection devices and balloon techniques associated with carotid artery stenting. The 2012 PROFI trial was the first randomized control trial to compare proximal occlusion using the MoMA Ultra system versus filter protection with the EMBO-SHIELD system. Using new ischemic lesion on brain MRI as the endpoint, despite being a single center study with a small sample size, it showed that proximal occlusion significantly reduced embolic load compared to filter protection. Similarly, a meta-analysis of a study comparing filter protection and proximal occlusion revealed a significant reduction in new ischemic lesion among patients treated with proximal occlusion. Predilation is generally avoided unless the stent or protection device cannot cross a tight lesion. Pre- and post-dilation may also cause embolization and vessel injury. So when predilation was performed less aggressively using balloon diameter under 5 mm, it was associated with a lower incidence of neurological events compared to predilation with balloon diameter greater than 5 mm. Furthermore, in a meta-analysis of 6 observational studies, post-dilation was found to be associated with a higher incidence of hemodynamic instability compared to procedure performed without post-dilation. So based on these findings, the 2023 ESVS guidelines have provided a Class 2A recommendation for selecting balloon diameter under 5 mm when predilation is planned, and have advised against post-dilation in cases where residual stenosis is less than 30%. In summary, while recent guidelines generally favor carotid endarterectomy over stenting, significant technological advances have improved the safety and efficacy of carotid artery stenting. The key advances include better patient selection based on age and risk factor, with evidence supporting carotid artery stenting in younger patients under 70 years. The introduction of TICA with dynamic flow reversal has shown the lowest stroke rate, offering a promising alternative to traditional transfemoral stenting. Improvement in embolic protection devices, particularly the superiority of proximal occlusion over filter protection, have significantly reduced embolic complication. Additionally, refined balloon technique using smaller balloon for pre-dilation and avoiding unnecessary post-dilation have further improved procedural safety. Thank you for your attention.